I'm Kristel Fortune. I'm one of the medical officers at Rahima ED, and I will be going through the approach to chest pain with you guys today. So, when we have to define chest pain, it's basically a general term for any dull aching pain in the thorax. Problem with that is if you think back to anatomy, there's many important structures underlying the area that is highlighted for where chest pain can occur. Where do we start? How do we diagnose? How do we treat? What is going to cause a patient to die right in front of you? Absolutely anything in the body can cause chest pain, whether it's a true chest pain versus a referred chest pain. Absolutely anything can cause. So important is to have an approach. When we look at an approach for chest pain, it is important to differentiate the causes between life-threatening causes versus non-life-threatening causes. Because if you do miss a life-threatening cause of chest pain, the patient will end up in a grave. An easy way to remember the life-threatening causes of chest pain is the 4-2-1 rule. So you can have 4 heart-related causes for the 4 chambers of the heart. These are your acute coronary syndromes, your aortic dissections, your pericarditis, myocarditis, and your pericardial effusions versus cardiac tamponades. You can have 2 lung-related causes, which is usually your pulmonary embolisms and your pneumothorax, and then you can have 1 esophageal-related cause, which is your esophageal perforation. This is a nice approach to a chest pain in order to make sure that you don't miss any of the life-threatening causes. So I know it's not displaying very well, but we are going to break it down. Whenever a patient presents with a chest pain complaint, you need to do a primary survey on the patient. During your primary survey, you need to evaluate your patient's airway, breathing, circulation, disability, and environment. Based on your primary survey, you need to determine whether your patient is stable or unstable. If your patient is unstable, you need to stabilize your patient first by supporting wherever you found the problem on your primary survey. Usually in life-threatening causes of chest pain, you actually have to fix the cause of the chest pain before you can actually stabilize your patient. So during your primary survey, you also need to look at obvious signs of life-threatening causes of chest pain. If your patient is stable, you will move on to a focus history and physical examination plus an ECG. It is important that your focus history and physical examination should not delay your ECG. You need a prompt ECG to make a diagnosis. During this process of getting your focus history and physical examination, you will do acute management for these patients, which include obtaining IV access, placing the patient on cardiac monitoring, as well as getting a BP and O2 reading, and then you only provide supplemental oxygen if needed. Once you have your ECG, you need to assess whether there's any signs of ACS. ACS will, if it is a STEMI, present with a localized ST elevations or a new left bundle branch block, which meets the Scarbosa criteria, but that is part 2 of the talk, which we'll be covering next week. If there's no signs of ACS on your ECG, you move on to assess whether there's any of the other life-threatening causes of chest pain. You do this by using your ECG as well as your H's and P's, your history and physical examination.